Hey guys, welcome this evening to our lecture, Plan, Plant, Drill, Efficient, Restoratively Driven Digital Implant Planning and Guided Surgery. I'm Zach Evans. I'm an assistant professor of periodontics at the Medical University of South Carolina, and I'm proud to be with you for this webinar. Quick overview, we're going to talk about what I've established that works for me and for our practice and in our teaching with our residents. Kind of as a formula for predictable implant surgery, I'm going to talk to you a little bit too about the rationale for guided implant placement, some things that we've learned and some cool projects that we've done recently, and let's discuss strategies that we're using for digital implant planning and how we can turn those strategies into a surgical workflow that we can use on a daily basis. And I'll share a couple cases with you guys. I love starting some of my talks with images like these. So we have an implant prosthodontist on faculty, and about once a week he sends us an image of a case that someone sends to him because they're just not quite sure how to restore or what to do with it. So this should be pretty obvious. It's a cross-section of a CT scan, restored implant, but the apex is obviously way outside the bony housing. This implant was placed, integrated, uncovered, and restored. Pretty amazing that stuff like that is out there. Another example, this one's more subtle. This is a really difficult case, actually, if you think about it from a perspective of freehanding an implant. So look at the rotation on tooth number 12. This would be a difficult case to freehand, but you can see on the scan body scan that the placement is definitely too far facial. So restorable in this case, but not ideal. Here's a case that we also got two things wrong with this one. So look at the access hole on the buccal of the implant crown, but also maybe more important, honestly, in my opinion, is look at the image on the right, the platform of the implant. It's just not apical enough. It's right at the surface of the gingiva. So angulation and depth in this case were inappropriate, for sure not ideal. And here you go. I don't even need to talk about this one. Look at the impression copings on this case. You know, how do we manage cases like this? How do they happen in the first place? Hopefully today I'll talk to you about strategies to obviously avoid extreme cases like this. But, you know, it's just unacceptable at this point, given the technology and some of the solutions we have access to. So here's my strategy and my formula, and that is, to me, success on a daily basis in the implant practice is really based on doing prosthetically driven implant planning and fully guided execution of implant placement. So there are a few technologies that we're using day to day to make this happen. The first in my hands is an intraoral scanner. So I use the Emerald from Planmeca. We also need a high quality CBCT scan. This is the ProMax. Again, you know, what we're looking for is just high quality diagnostic material that we can use. And finally, we have access as well to a really good 3D printer, and that's part of the equation as well. So the thing that brings everything together is the Remexis software that ties all of this together from a planning perspective and a software perspective, and makes the planning possible. And I'll talk more about how we put this into practice. So the execution side, I definitely think at this point in my career that a fully guided implant placement is really critical in my hands, and also in our teaching, to execute these cases really well. And I'll talk a little bit more about why we think that. And it's basically coming down to that there's overwhelming evidence that guided implant surgery is superior in really every measurable parameter you can think of. So implant depth or angulation, restorative prognosis, all of those things, if you measure them when you compare freehand implant surgery to guided implant surgery, even in the hands of really, really skilled and experienced practitioners, then guided implant surgery is really has an advantage almost in everything that we can imagine as far as quality. So, you know, once we have our CBCT scan, and our intraoral scan or digital model, we have enough that we can do prosthetically driven implant planning. And I'll walk you through what that means to me. And like I said, it starts with a good quality intraoral scan. A lot of general dentistry practices already have this technology in their practice. So for those of you who are doing CAD/CAM dentistry, this is already part of your daily practice. For people like myself on the surgical side, this is kind of a big leap, and this is something that we've had to learn to incorporate into our practice. We're really catching up with the restorative guys, but a good quality intraoral scan is really important. And that includes the arch that we plan to restore and place the implant on, as well as the opposing arch and a good bite registration, all of which are really important. And a high quality CBCT scan. So, you know, this is my assistant taking a scan, and we've found that if we combine really highly diagnostic quality scans with an ultra low dose protocol like we can do on the ProMax Mid here, that we can really minimize the radiographic exposure dose to the patient. At the same time, we can get good quality diagnostic images. And I think that if we kind of combine those things together, that it justifies the use clinically on a day-to-day basis. And, you know, thinking about exposure risk to the patient, I think the trade-off is worth it. And then obviously, we want to make sure that we get this information and combine it with all of those anatomic considerations that are really fundamental to implant surgery and placement. I won't go into those details, but having really good images is very important, so we can see what we're working with, you know, when we consider the anatomy in really critical areas: sinuses, adjacent teeth, quality and extent of the bone, location of nerves, fossa, etc. So it's important to think of all these things in combination when we're planning these cases. Once we have our diagnostic information, we have enough and we're ready to go ahead and do our digital wax up. And I think that by going through this process of planning implants from a digital perspective, it's really important to have a full digital wax up. And I'll show you a little bit of evidence that we've discovered about why. And from there, we can take that information and we can go ahead and plan our implants from a surgical perspective, of course, digitally prior to surgery, putting all of those things together. So let's play a little game before we go any further. Let's look at this cross section. This is a cross section from a CBCT. The purple line that you see is the intraoral scan overlay. So really what we have in this case is a CBCT with our intraoral scan merged. And this is a site that I did some pretty extensive bone grafting on. So plenty of bone to work with. I want you to get an idea in your mind of where you think the ideal implant position would be. And if we think about kind of those fundamental principles of implant placement and restoration, even if we want to screw-retained restoration, we want to think about a cusp-fossa relationship in this case. We want to make sure that the forces are distributed, you know, in parallel to the long axis of the implant. And we would hope that the implant emergence is centered on the opposing cusp to distribute those forces, et cetera. So if we look at this image, then my guess is that the ideal implant placement in your mind would be somewhere around there. Maybe a little bit different, but in that vicinity. It's really centered in the ridge. It looks like, you know, it's emerging and opposing the opposing tooth well. The problem is, though, that we're not really taking everything into full consideration, even from these views. So this is actually where the waxed up tooth would belong, and I'll explain how we get to this point. But look at the discrepancy. If I put the implant in and sent it to my referring dentist, and it were that far lingual, my referring dentist would be upset. The patient would be upset. They would have a restoration that's too far lingual. Their tongue would play with it. It would be a failed case. And we would have gotten to this failed case with a CBCT and an intraoral scan overlaid. So even with a good diagnostic image, we're still not having enough information to do a really good job. So this is actually where it's appropriate. And I'll explain why there's this big discrepancy between those two sort of fundamental positions. Let's think about planning from CBCT only. This is a study we're conducting right now that we hope to be finishing and publishing relatively soon. But what we've done is we've taken a large number of implant practitioners, most of which are familiar with digital implant design and planning. And we've had them virtually place implants under a variety of different clinical scenarios. So the first is placing an implant on a CBCT scan only, which a lot of practitioners will take a CBCT scan, look at it, and then decide, where the appropriate implant placement would be, and then a lot of times do the freehand surgery afterwards. So in this case, single edentulous site, number 8, there are a number of implants planned under different strategies, and I'll explain what those are. But you can see from a mesial distal bodily position and angulation position, there's not a lot of discrepancy between these implants. We've also combined the CT only with what about the scenario where we have an intraoral scan overlaid as well? And what if we have we call it a dummy tooth, where the software allows us to place and position an implant roughly in space based on, a virtual tooth that the implant allows you to, or I'm sorry, the software allows you to slide around into position. And what we find is that between those 3 scenarios, there's actually not a lot of difference. So CT only, CT scan with intraoral scan overlay, and then all of that in combination with we call it a dummy tooth that a lot of the softwares will let you place. There doesn't seem to be a lot of significant difference between those strategies. However, if we do a true diagnostic wax up, then we are seeing some significant difference statistically. In this case, maybe not clinically relevant, but we are seeing differences compared to a full diagnostic wax up. What does the full diagnostic wax up entail? Well, we're thinking mainly in this case, we're adding the addition of occlusion into the equation, where it's really hard to do that on the CT scan only. And again, on a single site, it may not be so dramatic, but let's think about another scenario. And here it is, sorry, from a lateral view. Even a simple case, look at the differences in potential angulation based on those separate strategies. So we're potentially incorporating in a lot of possible error in terms of implant position, just based on how much information we're willing to collect together in order to plan these cases. So how about this? How about a 1819 case? Not even a bridge case, but single unit posterior kind of molar case. When the case is not tooth bound, meaning we have natural teeth on either side that we can use as reference point if we have an intraoral scan or even just off the CT only, it really kind of falls apart. So, we can use our classic measurements about how far apart implants need to be, and roughly they need to emerge opposing the opposing ridge. But it gets really, really difficult. And even in an ideal world, in the computer setting, if we take away the ability to have a full diagnostic wax up, then here you go. You can see that these virtually planned implants begin to be all over the place. So I think the take-home message roughly from the research that we've done so far is that the guided digital implant planning strategy is actually really important when we think about trying to pull these cases off successfully. So, can we get away with a single unit anterior or posterior, implant case using CT only, or maybe with the intraoral scan or even virtual tooth that we drop in from a lot of the software programs? The answer is yes. I think we'd be okay. When we start thinking about multi-unit, bridge or long span edentulous cases, then we definitely have evidence now that it's very important not only to have virtual teeth in position, but to have a full diagnostic wax up. And I'll explain in detail about kind of my step-by-step process about how to make that possible. And we found that overall, especially when we start thinking about multi-unit cases, the differences just become more and more apparent when we add the variability of not having a true diagnostic wax up in these cases. So when we go back and think about implant planning fundamentals, there are some things that we know as dogma that we kind of go by day to day, these minimum distances and positions that we think about when we place implants. So obviously, we want implants to be roughly centered in the ridge between opposing teeth and implants. For anterior teeth, we want them slightly lingual, potentially emergence-wise and bodily position in a buccal lingual or buccal labial position. And we have these guidelines that we've gone by for decades now that, we need minimum tooth to implant distance of about 1.5 millimeters. That's for tooth health adjacent to prevent soft tissue encapsulation of the implant and to try to preserve papilla between implants and teeth. And likewise, we kind of have that magic number between implants, and it's 3 millimeters, at least for non-platform switched implants. And then this is probably one that most people, or a lot of people, don't know as well, but having at least, if possible, 2 millimeters of labial plate thickness for anterior implants, if possible, if the anatomy and the bone allow it. It really can prevent, or at least minimize, the risk long-term of soft tissue recession on your aesthetic anterior implants, as they're supported by the soft tissue and bone underneath. So, and then depth-wise, implant platform 3 millimeters below the facial zenith of soft tissue in the maxillary aesthetic zone. So, we have that kind of idea that for prosthetic success, that the implant platform needs to be below the soft tissue at least 3 millimeters, and that allows prosthetic emergence and adequate aesthetics, especially in the anterior. But I'd say that for free-handed cases, sometimes having an idea of where the where the restorative margin is going to be in space can be very difficult to get a good idea of. I remember as a resident, when I was learning how to do these cases, that we kind of take a perio probe and go from CEJ to CEJ, and then we measure 3 millimeters from there. It's just not ideal. So there are much better ways to execute those cases. But let's think about an anterior case. Here we go. We have a CBCT scan and we have the intraoral scan overlay. Even with this information, it still may not be enough to effectively have an idea, especially of implant depth and even emergence from a labial and palatal angulation position. We really do need a wax up in space that has all of those shapes and sizes and positions built in so that we can position our implant off of that. So having all of that in combination is very important, I find, especially for these difficult to pull off anterior aesthetic cases. So, and this is what we would see in 2 dimensions, cross-sectional view. This is an implant-centric view. And again, you have all of that information that you need to be able to really effectively plan the ideal position for these implants. So what are we thinking of when we create our prosthetic design? We're thinking about our gingival and restorative margins, especially, like I said, for these anterior upper kind of maxillary aesthetic areas. You really need to know where that gingival and restorative margin, it's a very important landmark. So having a good wax up is important. Compare that to the dummy tooth that we place, the softwares will let you place when we're planning implants. That might be impossible to really visualize effectively. In addition, we really want to be able to see the prosthetic emergence and contour of the tooth crown. That can help us figure out emergence as well. And then obviously occlusion and incisal edge position. So all of those in combination are important to have an idea of, I think, when we're thinking about positioning an implant in space. So once we have that, again, we kind of think about our anatomic considerations for balancing the position of the implant and putting that in the implant with adequate distances from implants and teeth. And once we have that in combination with the wax up, we can balance all of those things together. So it's like, I kind of joke, it's like being able to see into the future, because we have an idea of what the final restoration should look like. We can see it in cross-section. We can take measurements to make sure that our platform depth is appropriate. Like I said, one of the biggest mistakes that I made and that I see beginning dentists make is probably going a little too shallow with their anterior implants, especially implants that are not immediately placed. that's a problem that I see pretty often. So it's nice to be able to measure those things digitally before we commit to finalizing the implant position. And then it's really nice if we can verify these things in a virtual 3 dimensions. So, having an idea of prosthetic emergence in all kinds of views. I share these views with dentists who refer implants to me. But being able to see these can be really, really helpful. And even compared to some of the 2D views, I think that a volume rendering like this gives us a lot of information that's helpful when we're finalizing and confirming our restorative prognosis off these implants. So we've got everything together that we need. We have a CBCT scan. We have a intraoral scan. And from the intraoral scan, we've combined that with the upper and lower arches so that we can see occlusion. The diagnostic wax-up takes all those things into consideration. Now it's time to merge things together so that we can plan our implant placement. So one of the first steps is merging that diagnostic wax-up and the intraoral scan with our CBCT. And I find that that's probably one of the most important steps. The other thing that I find, and this is a pearl of wisdom that I'd like to pass on to you guys, is that when you take a CT scan for the purposes of implant planning, if you're going to go through a digital workflow like this, whether you're going to do it yourself or whether you plan on sending it off, do yourself a favor and make sure that the patient is in an open bite. So on a CT scanner, that means having them bite on the little bite tab. Or if you don't have a bite tab, if you're just using a chin rest, then giving them something relatively or really radiolucent to be able to bite on, like a little piece of styrofoam or maybe even a cotton roll. And what this means, if you look at the image on the kind of right panel, teeth with a large restorative history, they can be really difficult to merge together with your intraoral scans. So if you can see on those molar teeth that have been restored with crowns, they throw off a lot of artifact. Even if you play with the threshold settings to eliminate that, it's almost impossible to get that to go away. So sometimes the only landmark you can use to verify the matching of all that together are those little cusp tips. And I think you can see those on the scan. So really important to have an open bite. The one caveat, or I'm sorry, the one exception would be in cases where we do not have the need for an open bite, where we'd rather have it closed. So full arch cases, if the patient has a complete denture, then in those cases you would want them fully closed. And I'll show you about that in just a second. So let's look at a little video of the process of the merge. And when I'm teaching courses about how to do this process, this is really one aspect of the treatment that I really dwell on. It's so important. If you're doing it yourself, it's so critical to do a good job. And now that I've been doing this for a while, I wouldn't trust anyone else to do it for me. You've got to have a really good merge. So let's watch a little video of the process. So for those of you who are not really familiar, this is within the Remexa software that Planmeca makes. And they have a fit model tool, which is very easy to use. You select your prep arch and you establish a new match. And basically what you're doing is you're playing a game of connect the dots. You're going to play with the threshold settings on your CT scan so that you can eliminate some artifact. You can really play with the threshold setting, almost get rid of the bone if you want to. The enamel or restorative aspects of the teeth are so dense. And you're looking for common data points between hard tissue. So the only thing we have really are the parts that stick out of the gums into the mouth. So the clinical crowns of teeth are those aspects that we need to use to merge our intraoral scan data with our CT scan. So, we can do things like section the arch a little bit. We can play with the threshold. And what you want to do is you want to align each of these images kind of in the same orientation so that you can identify these common points. And when you do, you just kind of click the point from one scan to the CT scan, the equivalent point, clicking in the correct order for the software, and then finding a final point. And once you do, if you hit a third point, the software will automatically merge the two together to give you a proposal. And if you like it, you hit done. And at this point, it's going to run a find match algorithm. So it'll find to the match for you. And once it's done with that, it will give you a color mapping where areas that are well combined are going to turn green so that you can just sort of reassess the area. I highly recommend full arch scans for this process. If you take a quadrant scan or a sextant scan, you may have a hard time getting an accurate match, where if it's all the way across the arch, like in this case, everything's turning green, you can be pretty confident that you're getting a really high quality merging of your intraoral scan and CT scan. Obviously, if these things don't match perfectly, then that error will be built into the implant plan later if you make a guide. So here you go. Here's our CT scan with a perfect match of the intraoral scan. So very important process. And this would be something that you want to practice and get good at if you're going to be doing these cases in the future. But you can see it was really efficient. You can do the same process for edentulous cases using the denture dual arch scan technique, where you put radiographic markers on the denture. The new CT scanners are really nice. The Promax that we have, it lets you take model scans where you place the denture on the CT scanner. So you take it out of the patient's mouth and you put radiographic markers on the denture, and you place the denture on a little model bed platform on the CT scanner, and you take a CT scan of the denture alone. And you can generate a three-dimensional STL image of the denture itself. So a virtual computer model of the denture, highly accurate. And if you have the radiographic markers attached, you can see those on the surface of the STL model. And then you have the radiographic markers because you're going to place that denture back into the patient's mouth. And like I said, this would be the exception to the rule, where you would want the patient in a really ideal centric occlusion, if possible, with their chin on a chin rest, because that inter-arch relationship is going to be preserved in this case, because you have a model of the denture and all of the hard tissue data on the CT scan. And then all you have to do with that is you have to connect the dots, just like we did on the teeth, but using those radiographic markers to the denture scan. So denture dual scan is definitely something that's possible and easy to do on full arch edentulous cases. Once we have everything merged together, then we have what we need to position our implant virtually in space. So thinking about all those things we talked about when we were looking at the digital wax up, merged with our intraoral scan and CT scan, trying to figure out where that ideal implant position would be. Once we have all that together, then the final thing we need to do in order to plan a surgical guide would be to go ahead and place our guide sleeves into position as well. So before we do, it's very important that whatever implant system you're working with, that you become very familiar with a few things that you may have overlooked in the past. The first and most important thing is, what is the length of your drills? So it's possible that you can get around even having to know these things, because the software can default to set settings. If you put in a certain implant length, then there is, in some cases, for some implant systems, an implant drill length that corresponds to that. However, sometimes we want some flexibility. So like in this case, we have 2 guided drills and 2 non-guided drills. However, all the drills are the same. So you have the advantage of having 4 different drill length options that you can choose from for any given implant. When is this important? Well, if you're in the posterior and you're having clearance issues, which is very often the case, then you can go with a really short drill length, even if that's not necessarily the most appropriate drill length from the manufacturer's perspective. It just gives you that flexibility to be able to select what's most appropriate. And very important too, that if you're using a system that uses guided drill keys, that you consider the key length into the overall equation as well. So depending on how advanced of a digital user you are, you can kind of stick with the basics to make it really, really easy to do, or you can really customize these cases based on some of this information so that you can maybe pull off things that otherwise wouldn't be possible. Keep in mind, one caveat is sometimes the effective drill length is not always as advertised. So some implant systems intentionally have you over prepare and vice versa. So it might be nice, and almost just out of curiosity, to take your drills sometime and actually measure them. You might be surprised that they're a little bit different than what the manufacturer tells you. And for those of you who are advanced in this, you can think about your total drill length that you're going to use for these guided cases as a combination between a number of parameters. So most of the time, if you're using a keyless guided implant system, then it would be your total implant length plus the sleeve height, so the metal tube that you would use to drill through, plus the distance between the implant platform and the bottom of the sleeve. If you add those things together, then that is what you would end up using as your metric for total drill length. If you have a key in your system, it's important to know the thickness or offset of what that key adds to the equation as well. So the effective drill length, if you add a key, is actually shorter than it would be otherwise, right? So it's lifting the drill up a little bit. Important if you're going to be kind of really customizing cases for yourself. The software makes it easy, however, especially if you have a system where you know the drill length and you just want to go with that. Then all you have to do is enter the drill length into the software, and it will position the sleeve in space at the appropriate distance from the implant so that there's really no math involved. All you have to do is just establish the drill length, and the sleeve will be in the correct position in terms of height. So let me show you how that looks. Here's a case where we want to customize the drill length so that we can use the one that we select. In this case, we're going to toggle manually until the drill length equals the distance that we want. In this case, 18.5 millimeters for our drill that we choose. And there's our sleeve in space. So our implant's been positioned virtually based on the CT and our wax up. And the sleeve is now the appropriate distance for our drill length. And then we can rotate the sleeve in space as well so that we're not impinging on adjacent teeth. Or if you're using a notched sleeve and you want to be careful with the implant timing, then you can keep all that in line as well. So very easy to do in the software, and I'll show you how to bring everything together here in just a minute. But once you've got that, you're essentially ready to go to fabricate a surgical guide. And I'm at the point now where for every case I do, I'm considering a guided option. We have a lot of options right now. It's a really great time to be in implant dentistry. These examples are for dynamic guided navigation systems. So these augmented reality systems where you're using your hand to drill, especially on the top left with the X guide. You're using your hand to drill, but you're watching the screen, and the screen is giving you feedback about your implant position, your drill position as you're going in terms of angulation and depth. The one on the right, that's a new one, very expensive, robotically assisted. What I do on a day-to-day basis is fabricate a surgical guide, 3D print a surgical guide. I highly prefer this compared to the dynamic navigation systems at this point, because I don't have to worry about the inaccuracy of my own hand. Even if I have feedback from the computer, it just makes it really, really effortless when you drill through these. So this is the strategy that I'm using on a daily basis. I'm fabricating these 3D printed surgical guides using the software that we just looked at. And we have really good evidence now that if you're going to 3D print these guides in-house, and there are a lot of really great solutions to do that. We use the Planmeca Creo, so it's really, really effective and fast. I can print a guide in just over 10 minutes. And we found that the accuracy of these 3D printed guides, and this is based on a lot of published data, they're just as good as a guide that you would have professionally made. So, for me, if I send off and have a guide like the one I'm showing you here, made by a third party, that's going to cost somewhere between $250 and $500 in the US. And that's a lot, where I can fabricate this guide for, $5 to $10 worth of printed resin. So plus the sleeves, you know, the overhead on these cases is so much lower, but they're just as good as what we're getting from the outside. We do have a lot of strategies in terms of how you like to use these guides. So I found that a lot of practitioners that are veteran implant surgeons, they don't really love the idea of going fully guided. They want to use their existing drill kits. They don't want to invest maybe in new drills. And they may not want to invest in just the idea of carrying their cases through fully guided. So some of these guys will 3D print a pilot guide that can guide the angulation, but also depth in some cases of your initial twist drill. And that can be a really good reference point if you're very comfortable with freehand surgery to complete the rest of the case freehand. However, I tend to just go ahead and do a fully guided case every time. It really speeds up the surgery time. And for me, it minimizes just additional possibility of risk and error. If I'm going to go through the trouble of making a guide, I might as well go ahead and do a fully guided case. So you 3D print these, and then you insert the metal sleeve in place. And those metal sleeves are what really kind of intimately guide the drill position, angulation, and depth as you're doing these surgeries. And yeah, that's what I do on a daily basis. So once we have everything combined together in the software, and we have a vision for where the implant exists and belongs, we've placed our sleeve in position if we're going to use one for our guided case, then we're ready to go ahead and make our surgical guide. And I'm going to show you a quick video clip of this process. This step usually takes a couple minutes to complete. And basically there are steps. This software is nice because it walks you through the specific steps. First step is to assign a path of draw. You can go by the default path of draw. That usually works pretty well, but I typically set this manually. So you click a button, the path of draw is now set manually. Undercuts on the dentition are automatically blocked out. So these red areas are blocked out areas. So we don't have to worry about the surgical guide engaging undercuts and being hard to put on or remove. And then once we're happy with that, we can select the area of the arch that we would like covered by the surgical guide. And this really comes down to what you prefer personally. I like to have some cross arch stabilization in my guides. So I'll usually extend it to the other side of the arch. This helps make the guide more stable, and it gives my assistant and myself a little bit more to hold on to during the surgery. And it's going to give you a proposal with some of the undercuts blocked out. And at this point, you have to just trim it really quickly. And you can decide based on your surgical strategy and design, do I want to do this case flapless, or would I prefer to flap it if I like to flap it? Do I want to completely remove the flange? Would I like to leave a little bit of a flange to help with flap reflection during surgery? All those things can be customized, which is really impossible to do if you're sending this case out to be made by someone else. So in this case, I'm just going to trim off probably at the cervical area. Again, anything apical to the height of contour, the tooth is blocked out anyway, so you don't really need it. And just trimming this up a little bit. I think I used to spend a little bit too long on these. You don't really need to spend long at all. And beyond this, you can add things that make this appropriate for the case that you're doing. So we can add or subtract anywhere we would like. We can get rid of little thin areas if we don't want them. And we can cut holes on the occlusal surfaces if we want to be able to verify seating of the guide, so that we can see through the guide and look at the position of the guide in relationship to the teeth. And we can customize the guide as well. We can add text to the surface of it and add the patient's name or chart number, things like that. So most of the time, I'm pretty much happy with something like this. If you have large cases that have large kind of multi-edentulous spaces or spans, you can add bars for support. Those areas can be a little bit fragile. You can play with the thickness of these guides if you want to make them more or less thick. And then when you're ready, you can export these guides. And what it's going to do is export a STL image. So that's kind of a universal engineering three-dimensional software language that can be printed, 3D printed. So we'll export the STL of this. And again, we'll be able to visualize it back into the implant planning part of the software to make sure that we're happy with everything. But it's a very efficient process from start to finish, from wax up all the way to exporting the guide. I'm probably investing on average about 15 minutes. And we can apply this to really complex cases. So cases with guide stabilization pins, complicated full arch cases, it's the same process using the same techniques. We can use that and we can create a surgical guide for cases like that. So on a day-to-day basis, I'm mainly seeing cases that are probably 1 or 2 unit posterior, maybe anterior cases. That's probably my realistic, day-to-day case. So let me show you kind of what to expect or what you can accomplish with these cases. So, a full arch intraoral scan, CT scan, prosthetic design based on emergence and profile and occlusion for these restorations. And if you look at the two-dimensional cross-sectional view on the right, then we can look at the post-op periapical radiograph overlaid, and then we'll look at another example. Same thing. In this case, there's our post-op radiograph. So I find that on a day-to-day basis, kind of what you see is what you get with these cases, very predictable. And if you plan them appropriately, the surgical outcomes are extremely predictable. I've found that there's very little evidence, if any, that I'm getting error in these cases. So let's look at a case. This is a really difficult case, I think, if we look at it closely. We have a big discrepancy between the papilla on the mesial of 7 or tooth 2, 1, 2, sorry, for our international folks, and between our number 9 or tooth 2, 1 and the lateral incisor. We have a lot of, this is how the patient presented to us, a lot of recession on the mesial of the lateral incisor at the edentulous space. But look at the bite, look at the occlusion on this case, really deep bite. They're occluding almost on the soft tissue, on the palate, the incisive papilla. So hard case all the way around to think about how do we manage soft tissue aesthetics, but also occlusion, restorative emergence. Where's the ideal position for this implant going to be in space? We could freehand it, but this would be a tough one to freehand. And this is actually one of our student cases that we did here at the university. So I think that's a testament to using this system, how powerful it can be even in the hands of people who are novice users. So let's look at a video of walking through the planning phase. So this is the Planmeca Romexa software. And in the software, we can snag our intraoral scans. So we need our arch that we're going to restore. We need the opposing. And we need our bite scan. So once we have all those things, we have everything we need to go ahead and plan our case digitally. So we'll put all those together, make sure that we're happy with our bite, and then we can start to plan our case. So the first thing that I do is I go ahead and draw, just like if we were restoring a crown on the tooth, we want to create a margin. And this margin is where we expect or anticipate the soft tissue to restorative margin, in other words, emergence margin of the restoration, where it's going to be. So I take a second and I try to make this about as accurate as I can, because this is going to be an important landmark when we plan our implant. There's a clever tool in the software where you can draw a margin around the contralateral tooth. So in this case, the upper left central incisor. And if we draw a margin around it, then we get an immediate mirror image of that natural tooth. So that makes the wax up almost instantaneous in this case. So we just have to help position the tooth in space, help the software merge things together. And then at that point, it's going to merge the virtual tooth with that gingival margin we created. Now remember that we have some recession in this case, so we're going to have this appearance of recession, right? So in this case, we're going to use some easy tools just to manipulate this tooth a little bit to make it a little more restoratively appropriate. We'll look at it in cross-section and we'll verify and change our bite position. And that's essentially everything we need to do to plan this case. So the next step is to put everything together. Before we do, we need that additional diagnostic information. So we're going to get a CBCT scan. High quality scan is really important, but so is reducing dose to our patients. Using an ultra low dose, I get pretty good images. And then at that point, we need to go ahead and start merging everything together. So here we go again, kind of quickly. And this is all in real time. So here are the merging steps one more time. I think I explained the importance of getting a high quality merge, selecting common data points between both of the images. I like to spread these points out, so some in the posterior, some in the anterior. That really helps reduce the risk of these scans merging inappropriately. Once you have it together, the software will put it together for you and verify the quality of the merge. So there we go. Everything's merged. And what we need finally is to bring in the restoration, the wax up. So clicking some buttons, you just say use automatic match, that brings it right in. So that's a full diagnostic wax up brought into the software. We have everything we need now to go ahead and plan our implant. So verifying the merge, maybe one more time, looking at it in cross-section. And then here's our implant library. It's pretty robust in the Remexis software. Pretty much every system that exists is going to be in there. So you're going to pick an implant and add it to the plan. And just like we showed you in those kind of static slides, we're going to move this thing around until we're happy with the position. This is a difficult case. This is actually a case one of our residents did. And this would be a very difficult case, I think, almost impossible to freehand. There's not a lot of bone to work with, potentially even a little bony defect on the facial. So once we have it kind of roughly in position, I like to bring up this three-dimensional volumetric rendering. So any changes that we make in implant position, we can see the difference in real time about how that implant is going to emerge in space. So again, thinking about it from that restorative prognosis, we can immediately get a good idea of whether or not we're happy with the position and emergence of this thing. So such a difficult thing to imagine, I think, if we're freehanding implants, and it makes it so easy to do this virtually. Doing these guided cases can be very predictable and easy using this. And then using those measurement tools to verify our depth, very, very important for these anterior teeth to make sure that we're going to have a good restorative diagnosis. And if we're not happy with it, we can make some small changes. So we'll probably put it a little bit deeper here. And then we can add our sleeve at the end. I like to do this at the end just so it doesn't obscure the view of the restorative design and emergence of the implant. And then we'll rotate that sleeve around so it's in the appropriate position. In this case, it's got a notch because this can be a timed implant. So, platform position and depth can be controlled based on that. And then we can just verify that it's not impinging on the adjacent teeth. And there we go. That's everything we need to plan our surgical guide. So we'll jump right back into that surgical guide planning module. We'll select the area that we want covered by the guide. And once we do, we will go ahead and have the computer generate a proposal and then trim that up and customize it as we see fit. It's really nice, like I said, to have full control over this process. It's something I really enjoy because I've found a lot of scenarios where, if I had gotten a guide from a third party, there might have been some subtle things about the case I didn't even think about until afterwards or while I was planning it. that I was glad that I had control over it. And it's such a quick and efficient process that, again, I think it's hard to justify sending these out when they can be made in-house so easily. Here we go, we've got it trimmed up. We can add some support if we want to. Remember, with the bars, we do have the holes created so we can verify seating of the guide. I find that for pretty much every case, I don't really have any trouble with seating, but I always feel better when I can see it. You can customize with the patient's initials onto the guide, and you can export it for 3D printing. And that's it. That's all we need to do. Now we have the file in place. So this is a video of the entire process, planning from start to finish, from wax up to export of the surgical guide. Once the surgical guide is created, we'll print it on the Creo, and within 10 to 15 minutes, we'll have this guide in hand, and then we'll do our post processing of the resin. So here we go. Here's the Creo printer, about to get started, and very, very fast print. So we'll do an alcohol wash and then a UV cure afterwards, just like the manufacturer recommends for processing, so it's safe to use inside the patient's mouth. Sorry. And then we're ready to go. So just like the cases before, here's our plan on the right side. And the post-op periapical radiograph, this implant did torque, and we were prepared to go ahead and temporize immediately with a 3D printed temporary restoration. So here's the case. This is day of surgery. It's just a stock temporary abutment put on the implant. And remember, we have a digital wax up. We know the position of the implant. We know that we have the intraoral scan. All of that in combination together allows us to fabricate a temporary prosthesis that we can slide right on the temporary abutment. So within the information that you have, if you're a powerful digital user, you can take that info and either 3D print or mill a temporary restoration, which is what we did in this case. Please remember, this is a student case, so we had dental students and residents really taking care of it. We intentionally under-contoured at the gingival margin for the temporary restoration, probably a little overzealous on the blue stain at the incisal. We wanted some tissue to creep down on the gingival margin, so like I said, we under-contoured, hoping that we could get a little papilla fill. I'm not sure that we did, but that was the intent and why we created the contour like that. But pretty good outcome, time of surgery, low overhead, and we're very confident that the implant position for this case, difficult case, is going to be as ideal as possible. So here's after uncovery, or I'm sorry, after transition to the final abutment. So a customized abutment was made, and the dental student milled a crown in this case, and here we go. There it is in position, and the final smile. So, you know, in my hands, using this process makes doing implant cases like this pretty predictable and easy. And where before I might have lost sleep over a single central unit incisor with deep bite occlusion and difficult gingival aesthetics, where now we can put it in the hands of dental students and residents, and they can pull off cases like this. So it's really, really nice. There are a lot of new implant systems that are coming out that are really becoming compatible more with at-home 3D printed options. So this is a case where we designed it just like before, did the wax up, and created a surgical guide, but there's no sleeve. So there are a lot of implant systems now that are being developed to be drilled directly through the 3D printed guide. This is a case that shows that. This is literally my first time doing it. This is a few weeks ago. So I was a little bit timid. I didn't know how the drill would feel, but here you go. No sleeve in this case. So, you know, as far as efficiency and low overhead, that's about as good as you can get. So there it is. And then it's just a couple more drills after that, and the case is done. So some of these, look out for these new systems that are compatible with drilling directly through the guide. And here's the case. And there's the implant in position. So again, exactly what you plan is exactly what you get. What about cases like this? You know, where do you even begin? So for us, it's the same principles, and I won't go into too much detail about managing a case like this, but using those principles of diagnostic wax up, combining that with information inside the mouth, you can really strategically plan cases like this. This is a staged extraction, grafting case, but it's using the same principles. And from this top left image, we get to a point where we have a diagnostic wax up that we see in the CT scan overlay. How do we get there? A case like this requires a little more work than just getting the intraoral scan. It really requires a good kind of smile design so that we know the position and proportion of the smile and the lip contours and the smile line and all of those things. But we did a diagnostic wax up, and from that we were able to create a surgical guide, place the implants. We had a temporary bridge placed on these teeth. These teeth were slated for extraction, but the implants torqued and we were able to convert directly to a temporary prosthesis. Again, just like the other case, we took our 3D plan that we had created in the computer, and we 3D printed this temporary prosthesis out of temporary resin. So difficult case, really difficult case, and we were able to pull it off pretty predictably with implants, with a 3D printed temporary prosthesis, and just some simple direct composite restorations on the bottom to create a new occlusion for this patient. And that was very successful. So yeah, here we go. And then sky's the limit. You can use these techniques to create hybrid prosthetics. This is one that we 3D printed and delivered day of placement. So this patient was a dentulous, had a denture, and we did the denture dual scan. And from that, we were able to plan a surgical guide, place implants, put temporary abutments on the same day. And we had, from the dual scan, we basically just created a 3D rendering of that denture that she was wearing and 3D printed that and included the emergence access from where the holes would be for creating this prosthesis. So compared to converting a chairside denture fixed hybrid prosthesis, you can have this in hand before you even start the case. Makes it really, really easy. So cool stuff we can do with this technology. And I think in conclusion, I would say that bringing all of this together, some keys for success are having a really high quality restorative plan. So prediction of what the restoration should look like, right? Where does this implant belong restoratively? Having a high quality intraoral scan and CBCT merge. I think I've talked about that enough that it's very important to have a good quality merge. And then creating a really good surgical guide design. And from that, it's pretty easy to execute these cases. I use this Planmeca software that I showed you today, mainly because, and we have access to a lot of different systems here at the university, and I find that myself and even the residents who can kind of pick and choose whatever they want on a day-to-day basis, they kind of come back to this software because it brings everything together so well. It's simple, but it's powerful on a day-to-day basis. It makes things really predictable. So I really appreciate your time. I think we have a few minutes for some questions. But yeah, thank you so much. I really enjoyed doing this for you guys today. So let's see. Okay, so I've got one question here. What company, please, makes the drill for the sleeveless guide technique? Okay, so just for full disclosure, I am not paid by any implant companies. So if I say anything, they're not paying me. That was a Megagen case. There are a few sleeveless systems that I know of, but that's probably the one that I've seen that's becoming most popular. Is Megagen. Look out for them. But I can tell you that a lot of other systems are working on drill kits that are compatible with that. There is a little bit of a downside, or really only one downside I can think of for sleeveless guide cases. And it's also the same for cases where it's a top down or a stepped length approach um, guided case, and that is that at the end of the drill, the twist drill, there's a large diameter kind of, I don't know, 6 or 7 or maybe even more length, kind of large diameter drum at the end of the drill. And what that means is that the effective drill length might be a little bit shorter, or vice versa, that the drill has to sit up a little bit higher in the mouth because of that. So I found that that's probably the biggest drawback, is that access can sometimes be a little more difficult. But that's a really picky thing to say, because we're talking about the difference maybe of a couple millimeters. So yeah, these sleeveless systems, I think they're going to become more popular, and you know, it probably is going to save you 10, 15 bucks per case if you're buying sleeves for every case. So it's kind of nice. And I'll tell you, even though that was my first time drilling through one of those systems, it really is smooth. And I think you saw that the outcome was pretty predictable. So yeah, thanks. I'm not sure I see any more questions. So again, I really appreciate your time. Thank you so much. You guys, I'm Zach Evans. I'm at the Medical University of South Carolina. If you have any questions for me, you can just kind of look me up and send me an email. I'm happy to help you out. Really enjoyed it. Thanks.